Hey guys, welcome back to my channel, The ENT Resident. Today we'll be doing a topic that a lot of you have been requesting me for a while, and we'll be doing a case discussion on buccal carcinoma, one of the subsites of oral cavity cancer. We'll start with the history, we'll discuss all the history points, what does it indicate, and then we'll move on to our clinical examination, we'll come to our summary and then provisional diagnosis. What would be a differential diagnosis and how will we manage the case? You can also now purchase my notes. I have added links in the description. Okay, so let's get started. So, our patient is Ravi, a 65-year-old male residing in Hyderabad, farmer by occupation, who came with a chief complaint of ulcer in the inner aspect of the right cheek since the last 4 months. Moving on to history of present illness, our patient is apparently asymptomatic 4 months back when he started complaining of an ulcer in the inner aspect of the right cheek, which was insidious in onset, rapidly progressive in nature. Initially, it was a size of about 1 to 1 centimeter, but then it grew rapidly to attain the current size of 2 to 3 centimeter. Initially, it was painless, but he has started having pain since the last 2 months, and this is also associated with loss of appetite. Coming to all the negative history, now this is not a former title under which you should write in your case sheets, but these are all the history that you should be taking from your patient and include it under your history of present illness. So there is no history of bleeding from the lesion, difficulty in opening mouth, trauma to the cheek or any sharp tooth, halitosis, difficulty in chewing, difficulty in speech, excessive salivation, any recurrent ulcer or red or white patch in the mouth before this lesion, loosening of tooth, prior radiation exposure, difficulty in tongue protrusion, drooling of saliva, difficulty in swallowing, any other swelling in the neck, loss of weight, high risk behavior, any history of ear or nose complaints, and history of cough, breathlessness, hemoptysis, bone pain, abdominal pain, and jaundice. I'll talk about each one of these negative history if it was present, what would it indicate in a little bit. Moving on, past history, there's nothing significant as such. There is no history of surgeries in the past, no drug allergy, no history of cancer in the family. Coming to personal history, the appetite has decreased over the last 3 months. And very important over here is our addiction history. So he has been a beady smoker 8 per day in the last 40 years, and he has been chewing quid 4 times per day since the last 45 years, and he keeps it on his right gingivobuccal sulcus. So that's about our history. Now let's start from our first complaint. Now, the only chief complaint that the patient has presented to us with is an ulcer, which is in the inner aspect of the right cheek. So that first, when you hear this, you should have a list of all possible causes that could be when you see an ulcer in the right cheek. So first, the question that we need to know is what are the different causes of ulcer in the buccal mucosa? Now, I have classified them according to the type of cause. So, we have traumatic causes like the presence of a sharp tooth, or maybe a cheek bite, or any denture irritation that could be present. Next, we have infective causes, which can be bacterial, viral, and fungal. Examples of bacterial could be tuberculosis, syphilis, actinomycosis. Viral ones could be herpes simplex virus or cytomegalovirus, and fungal infections could be histoplasmosis, candidiasis. So these are infective ulcer causes. Next, we can have inflammatory or immune mediated causes like aphthous ulcers, lichen planus, pemphigus vulgaris. Neoplastic causes, which we are discussing today, which is squamous cell carcinoma, could also be a varicose carcinoma or a lymphoma or a minor salivary gland tumor. We can have premalignant or dysplastic lesions like leukoplakia, erythroplakia, oral submucous fibrosis, where you can have an ulceration due to trauma on the region. We will discuss about leukoplakia, erythroplakia in a little while. If you remember in the negative history, I mentioned if there is any history of red or white patch in the cheek. There can be drug induced causes of ulcer also, like NSAIDs, methotrexate, cytotoxic drugs, even radiotherapy and chemotherapy. There can be granulomatous diseases like TB, syphilis, vaginous granulomatosis, sarcoidosis, etc. And last of all, there can be systemic diseases or hematological disorders like agranulocytosis, leukemia, anemia, nutritional deficiencies like iron, folate, B12. So these are all these list of causes. The moment a patient has come to you presenting with an ulcer in the right cheek, instead of jumping to conclusion, we are just going to think of this list first. Then we'll proceed to ask about more questions associated with it and try to rule out a lot of these causes and come to a diagnosis. Okay, moving on. So we are seeing in the history that the patient has said that this is a rapidly progressive ulcer. So initially it was a size of 1 into 1 centimeter, but it only took him 4 months to attain the current size of 2 into 3 centimeter. That means that this is a rapidly growing ulcer. What does that indicate? So this, when we see a rapid progression versus a very gradual insidious progression, rapid progression always indicates towards some aggressive behavior that will point more towards malignancy rather than a benign cause of an ulcer. So when we are seeing a rapid progression, basically this is possibility of tumor is higher and the tumor is possibly invasive and it is actively proliferating. So that is the inference that we draw from this progression that we have asked our patient. Next point is he said that initially he did not have any pain, but the pain has started in the last 2 months. Now, what is that pointing towards? So, starting with painless. So, if since we are discussing a malignancy here, let's try to understand how does it fit into the picture of a malignant ulcer over here. So, when we have an early squamous cell carcinoma in the buccal mucosa, initially it is painless. What are the reasons for it? Because the lesion is very superficial. It has only involved the epithelium and the lamina propria. If it has not undergone further deeper infiltration, usually we do not have any pain. And also at an early stage of the malignancy, we do not have any nerve involvement. These are the two reasons why the early squamous cell carcinoma of the buccal mucosa will be painless. But as the disease keeps progressing, and we have found out that this is progressing very rapidly, in within a few weeks or months, it may start to have pain. So the patient is complaining of pain to us. What are the possible scenarios over here? So one answer for this is if there is any perineural invasion. So if we have any perineural invasion, where the tumor has infiltrated some sensory branches of the nerves in the buccal region, like the buccal nerve or the lingual nerve, this can cause a neuropathic pain. And the neuropathic pain is usually radiating or burning in nature. Second cause would be if there is deep tissue infiltration. So if the mucosa, if the tissue has extended from the mucosa and lamina propria to involve the muscle underneath it or the submucosa, or even gone deeper to involve the periosteum of the bone underneath, which can be the alveolus or the mandible, in that case, they'll end up irritating the nerve endings. So you'll have pain because of deep tissue infiltration. Third cause is, say it has not invaded into the deeper structures or any nerves, but the ulcer is as having a secondary infection. So when there's a secondary infection happening in the ulcer, in that case we'll have necrosis and bacterial infection, and that will lead to an inflammatory kind of pain. So this is our third cause of pain. Fourth cause is if it has involved the masticator space or the pterygoid muscle, it can cause a dull aching pain which gets aggravated by chewing or mouth opening. So these are all the reasons why a initially painless malignant ulcer can actually turn painful. Next is coming to all the negative history. So we have taken a bunch of negative history here, but each one of these points actually has some kind of indication towards some disease. So let's talk about this, each one of these points. Starting from bleeding from lesion. Now, if the patient had complained of bleeding from the lesion, and this is a malignant ulcer case, what would it indicate? First of all, it would indicate surface necrosis. So, as a carcinoma grows, a lot of rapidly proliferating cells are seen over here. Because they are all rapidly proliferating, they kind of outstrip the blood supply that supplies them. So, it has outgrown the blood supply that it has, the region. This leads to development of ischemia and necrosis over the overlying mucosa. And once this necrotic slough over the tissue, necrotic slough tissue starts to fall off, in that case, it leads to ulceration. And even if there is any minor trauma over here, maybe from brushing the teeth or like when you're chewing food or even when speaking, this can lead to bleeding. So that is the importance of taking the history of bleeding. So we'll know if there is surface necrosis over here. Second is it also suggests that the tumor has increased vascularity or friability. So usually malignant tumors, they end up developing abnormal fragile neovasculature. Basically, angiogenesis is happening over here. And in angiogenesis, these capillaries that are forming in this region, they are usually very thin walled and they can easily get disrupted. So even a minor trauma like contact with the teeth or any food can end up in frank bleeding. Third is if there is bleeding from the lesion, it can also indicate the presence of advanced local disease. Usually in early cancers, we do not find bleeding because the mucosa is very thick. It has not yet started breaking down. In the advanced stages, maybe in T3, T4, in these cases, the bleeding typically happens because they have broken through the mucosa. And last of all, if we have secondary infection, in that case also we can see bleeding to happen more easily. So these are all the causes why a malignant ulcer may bleed, and these are all the inference that you can draw from it. Next is difficulty in opening our mouth. Now, our patient has not complained of difficulty in opening mouth, but in case he had, what would that mean? There could either be the direct infiltration by the tumor, including the muscles of mastication. That could be one possible reason. And when muscles of mastication are involved, it leads to restricted mouth opening. Second is if there is secondary fibrosis happening because of chronic inflammation. So, any chronic inflammation around the tumor region or from repeated trauma happening because of a sharp tooth, it can lead to development of cicatricial contracture of the mucosa and submucosa, leading to difficulty in opening mouth. Third is it could actually involve the temporomandibular joint. In that case, it will be an advanced disease when it has involved the temporomandibular joint. So, this can go and invade either the joint or the mandibular ramus or the coronoid process of the mandible. Last reason is if the difficulty in opening in mouth is happening secondary to oral submucous fibrosis. So we know that oral submucous fibrosis is actually a pre-malignant condition, pre-malignant lesion of the oral cavity, and it has about significant of about 7 to 13% chance of developing into a malignant transformation. So if you have oral submucous fibrosis, in that case what happens is we have submucosal collagen deposition and fibrosis happening, so it leads to trismus is basically difficulty in opening mouth. When a malignant ulcer develops in this field, trismus is compounded by the tumor infiltration as well. So these could be the possible reasons why you could have your patient could show a difficulty in opening mouth. Now we just learned the term trismus. What is trismus? Trismus is basically difficulty in opening mouth. So if we had to define it, trismus is the restriction of mouth opening which occurs due to spasm, fibrosis, or infiltration of the muscles of mastication or temporomandibular joint. Now, why is it important? If our patient had limited mouth opening, what does it? How does it affect us? First of all, is you will not be able to examine the oral cavity properly because of the limited mouth opening. So you will not be able to assess the tumor margins. How far has it extended? You will not be able to assess the extent of the tumor. Second is, as there is limited mouth opening, your patient will not be able to maintain their oral hygiene. Maybe when they are eating food, however difficult it might be, either they're if it is very progressed, then in that case they're not able to intake food, so it will hamper the nutrition. And if it is not progressed that much, if they are eating food, maybe they are not able to clean off their mouth properly and maintain proper oral hygiene. That will lead to further increased chances of having secondary infection, and this secondary infection can lead to bleeding from the ulcer. So that is one important feature over here. Third is this will affect the anesthesia that you're going to give the patient and intubation during the surgery. So you'll have to find another way to do it. And fourth is, if trismus is present, it also indicates that this is possibly a very locally advanced disease. It must be involving the masticator space or the pterygoid muscles. So that is the importance of trismus here. Now, we were talking about the muscles of mastication. We should know what are the muscles of mastication. The mnemonic to remember it is MTP. So with M, we have masseter, T, temporalis. With P, we have two muscles, a medial and lateral pterygoids. Now, it is important to remember it's actually sometimes we confuse buccinator because of the place where it is present to be a muscle of mastication, but buccinator is actually not a muscle of mastication. We have four muscles of mastication and we remember it with MTP. Next, moving on, we have taken a history of trauma to the cheek or any sharp tooth. Now, what is the significance of this? If you have any trauma to the cheek from maybe biting it or maybe constant irritation by a sharp tooth, all of this constant chronic irritation can lead to be a predisposing factor for malignant change, especially if the mucosa has already been exposed to tobacco, areca nut, or submucous fibrosis. So that is why we need to take the history. So as to find out what is the causative factor over here. Second, a lot of these patients actually come to you with halitosis as well. Why? If they have, maybe one possible answer is if they have a restricted mouth opening, they're not able to maintain a proper oral hygiene, and that will lead to accumulation of food debris inside the ulcer cavity. That will lead to development of a putrid odor coming from it. Second reason is if there is necrosis and ulceration of the tumor surface, where I have told you when the tumor outgrows its blood supply, that leads to the development of ischemic necrosis, and that is how the ulceration and then slough formation will happen on the surface. And this necrotic area kind of becomes a breeding ground for secondary infection by anaerobic bacteria. And these anaerobic bacteria, what they do is they break down proteins to release sulfur compounds. And these sulfur compounds have this characteristic foul smell. These are the reasons why you will be seeing halitosis in a case of malignant ulcer of the buccal mucosa. Next is difficulty in chewing. So, difficulty in chewing would indicate that the patient has involvement of the buccinator muscle, possibly, or the pterygoid muscle or the masticator space, or possibly they have fibrosis from an pre-malignant lesion from before, which is an oral submucous fibrosis, or they could possibly have pain while chewing. That is why they're having difficulty. Why is this pain over there? Maybe there is a deep ulceration or periosteum involvement. So whenever you're trying to chew, you're having pain during mastication. So you're having some difficulty. Or if there is involvement of alveolar ridge or the mandible, and this will lead to loosening of teeth and pain on biting. So these are all the possible reasons why this patient may have difficulty in chewing. Coming to difficulty in speech. Why do we need to know this? Now, speech is, there's a lot of structures that are involved when you are trying to speak. So if the buccal mucosa is involved in the cheek, buccal mucosa and cheek has been involved, what it will do is when you're trying to speak, you'll have pain. It'll end up limiting the cheek mobility and the lip mobility. That will lead to impaired articulation of certain sounds like the labial sounds and the alveolar sounds. Second, if there is tongue involvement, say the lateral border, the anterior two-third of the tongue has gotten involved, this will restrict the tongue mobility significantly, and that will affect the pronunciation of lingual consonants. So hence that will end up with difficulty in speech. If you have trismus, there is a limited mouth opening, and you'll not be able to do the usual tongue and jaw movements that you usually do during speech. Lastly, if it is extended to involve the palate or the oropharynx, that will alter the resonance and nasal escape during the speech. So, these are all the reasons why a patient of buccal carcinoma can end up having difficulty in speech. Next is excessive salivation. Now, reflex salivation can occur when there is some irritation happening to the oral mucosa. So, ulcer is an irritation to the oral mucosa. And because the buccal mucosa is very richly supplied by sensory nerves, we'll have this reflex salivation coming from it. So, because of the ulceration or inflammation happening over here, it'll end up irritating the mucosal nerve endings. And when these mucosal nerve endings get irritated, they reflexly stimulate the parasympathetic salivary centers, leading to increased salivary flow. So that is one reason you are having an increased salivation because of the irritation. Second is, if there is no increase in salivary secretion, but you're not able to swallow the saliva effectively. When that happens, maybe there is involvement of the mucosa of the cheek, the retromolar trigone, or the soft palate, and the patient is having pain while swallowing, trismus, and reduced oral cavity space. So, all of this together, they are not able to swallow the saliva properly, even though the amount of salivary production has been normal. Then, what will happen is the saliva will start to drool out of the mouth through the angle of the mouth, or it will accumulate in the mouth. These are the two possible causes of excessive salivation in these cases. Next is recurrent oral ulcers or a history of white or red patch in the mouth. Now, white or red patch indicates what? The white patch will indicate towards leukoplakia and the red patch will indicate towards erythroplakia. We'll discuss about this later when we are talking about pre-malignant lesions in the oral cavity. So, whenever there's a history of such a thing, it will basically indicate the presence of a pre-malignant lesion. Second is it will also suggest the fact that there has been a long standing carcinogen exposure that first a pre-malignant lesion has developed and then the pre-malignant lesion has undergone a malignant transformation. So in that case, the history that you'll need to take is whether they are users of smokeless tobacco, betel quid, or areca nut, or if they do reverse smoking, or if there is a usage of alcohol. Alcohol has a synergistic action on the effect of smoking in cases of oral cavity cancers. So, these are all the reasons why you should know if there has been any pre-malignant lesion inside the oral cavity. Next, we have a history. We have taken a history of loosening of tooth. Now, whenever we are taking a history and this history is positive, what it indicates is probably that the disease has progressed beyond the mucosa and submucosa and has involved the mandibular or the maxillary bone and therefore involving the alveolus over there, leading to loosening of tooth. So, this is basically indicating bone infiltration, which will suggest an actually advanced stage of disease, like T4 stage of disease. So, that is one indication of this. Second, taking a history of prior radiation exposure. Now, we know that there are incidences of radiation induced second primary malignancies, which usually happen maybe somebody has been exposed to a lot of radiation because of some previous early head and neck cancer. So the whole head and neck region gets exposed to radiation. Now, usually after such an incident happens, maybe after 5 to 10 years of this exposure, they can end up developing a second primary malignancy. So that is one possible reason why we are asking this. Second is if the patient has recurrent disease in a previously aerated field. So one is that we have found a second primary malignant tumor has come. Second is if there is a recurrence in the tumor happening. Third important factor is field cancerization. Now, we'll talk about field cancerization later today. Here, a new primary can develop due to carcinogen exposure and a previous radiotherapy damaged. And second is, it will also indicate that they'll have reduced tolerance to irradiation. Why? Because if tissues have already received radiotherapy at its near maximal dose, re-irradiation in the same area could actually be risky or even contraindicated. So, taking a history of prior radiation exposure is very important over here. Next is difficulty in tongue protrusion. Now, what would that indicate? That would indicate the involvement of the buccinator muscle or the floor of the mouth muscle or even the tongue muscles. It can also involve the pterygomandibular space or the masticator space. And if there is fibrosis secondary to radiotherapy or oral submucous fibrosis, that will also lead to difficulty in tongue protrusion. So, these are our three causes why these patients can have difficulty in tongue protrusion. Next is drooling of saliva. Now, drooling of saliva, what will it indicate? It will indicate that there has been a loss of oral competence, which can happen because of either tumor infiltration of the cheek or on the lip in the oral commissure, which is the angle of the mouth. And this will be a feature of advanced local disease. Next feature that we have asked, next point that we have asked about is difficulty in swallowing. Now, if this patient presents to you with difficulty in swallowing, what would you think of? One is that possibly there is a posterior extension of the tumor happening, that the tumor has maybe spread posteriorly to involve the retromolar trigon, the pterygomandibular raphe, or the oropharyngeal isthmus, mechanically leading to narrowing of the oropharyngeal inlet. Second is if there is involvement in the muscles of mastication. When the muscles of mastication get involved, we have restricted mouth opening, as we have discussed before. And these patients, they're not able to chew properly or propel the food backwards. So, what they have is known as pseudo dysphagia. It is not absolute dysphagia. This is actually pseudophagia. This is not. This is a perceived feeling of difficulty in swallowing. Third cause is if there is invasion of the soft palate or the base of the tongue. So, if the lesion is very advanced stages in T3, T4, it will end up involving the soft palate and the oropharyngeal wall, leading to true oropharyngeal dysphagia. And last of all, it can also happen because of deeper infiltration, where it involves the masticator space, the constrictor muscles, and that would indicate a very advanced stage of disease. Next is if there is any other swelling on the neck. We know that buccal carcinoma can have lymphatic spread, and usually they involve the level 1B, level 2 lymph nodes. We'll talk about that as well in a little bit. So, a possibility of having a malignant lymph node is also very high. So, we should definitely examine the neck as well. Loss of weight is more of a systemic effect of malignancy where you have cancer cachexia, but usually in oral cavity cancer cases, we do not see loss of weight as much because the tumor bulk is very low. Because of this, to develop cancer cachexia, it takes more of tumor bulk. So, most cases will not come to you with a loss of weight history. Whereas other malignancies, like maybe GI malignancies, they'll definitely have a loss of weight as a feature when they present to the doctor. Next, we have asked about a history of high risk behavior, like, for example, having multiple partners, etc. Why is this important? Why is high risk behavior important in relation to oral cavity cancer? So, in high risk behavior, we can have transmission of the human papilloma virus, the HPV virus. And HPV virus can actually cause verrucous carcinoma, which is another variant of carcinoma that we see involving the oral cavity. So, HPV is actually not the most common cause when we are thinking of oral cavity cancer, but rather it is more commonly involved in oropharyngeal cancers. But the high risk oncogenic strains over here would be the HPV 16 and 18, out of which HPV 16 is more common. So, taking a history of high risk behavior is important to find out if there has been any exposure to HPV virus transmission. Next, we are asking about ear or nose complaints. Now, we have a problem in the oral cavity. Why do we need to know about ear or nose complaints? So, one of the history could be if a patient presents to you with ear pain in a case of buccal carcinoma, but you have examined the ear and you have seen that there is no issue at all over there. What would that mean? This would be a case of referred pain. Referred pain is when there is a common nerve supply. So the pain is referred from primary area to another area. So in this case, it is happening because of tumor involvement of the sensory branches of the trigeminal nerve mandibular division of it. Typically, the nerve involved here is the auriculotemporal and the inferior alveolar nerves. These are the reasons for referred pain to ear in a case of buccal carcinoma. Second is if the patient complains of ear fullness or hearing loss. This would be a result of eustachian tube dysfunction. Now, how is the eustachian tube getting dysfunctioned in a case of oral cancer? If the tumor is advanced and it has extended posteriorly to involve the oropharynx and the nasopharynx, we know that the eustachian tube opening lies in the lateral wall of the nasopharynx. So, if the nasopharynx has gotten involved from it, it will lead to eustachian tube dysfunction, leading to ear fullness or hearing loss. Coming to nasal complaints, if the patient is complaining of any nasal obstruction, discharge, or epistaxis, it usually indicates extension into the maxilla or the nasal cavity via the upper alveolus or cheek. Second is if the patient complains of postnasal drip or nasal twang in the speech, it will imply that there is involvement of the soft palate or the oropharynx. A very important question here, something that you should remember while you're taking history, is the 6S that you need to remember when you're taking any history related to oral cavity. So the 6S's are smoking, spirit, which also means alcohol, syphilis, sharp tooth, spices, sepsis. So those are the 6S related to the oral cavity. Next, you also need to take some history that may indicate if there is distant metastasis in the patient present or not. So the histories we have taken is cough, breathlessness, hemoptysis. These three, they will be indicating involvement of the lungs. The lung is the most common site of distant metastasis in oral cavity cancer. Next, bone pain would indicate involvement of the bones, and abdominal pain and jaundice would indicate the involvement of the liver. So, lung, bone, and liver, these are the most common sites that get involved if they do get involved. But distant metastasis is quite uncommon in oral cavity cancer with the chances of only 4 to 5%. Now, amongst these sites, as I mentioned, the lung is the most common site. Second is the bones. And usually, amongst the bones, it involves the vertebrae, ribs, pelvis, skull, and the long bones. And it can present with bone pain or pathological fractures. Third site is liver. Liver is the most common visceral site right after lung and bone, and this will again indicate advanced disease. And the rarest site to involve is the brain, which can occur very late in the disease course when in a patient who has widespread metastasis. So these history will help us in finding out whether the patient has any history of distant metastasis or not. So that's all about the negative history. I hope you have understood the importance of taking each one of those points as it will indicate more features about the disease or how much it has extended, what structures it has involved. Now, coming on to the addiction history. So, in any case of carcinoma, taking the addiction history is very, very important. So, we have found out that our patient has been a long term bidi smoker and he also chews quid and keeps it on the right gingivobuccal sulcus. Now, let's try to understand what is the mechanism of these factors over here leading to the development of carcinoma. What are the carcinogens over here? So, starting at tobacco, this person has been a bidi smoker. So, they have been exposed to tobacco a lot. So, what are the carcinogens that we have in tobacco? These include polycyclic aromatic hydrocarbons like benzopyrenes, heterocyclic aromatic amines, some aromatic amines and aldehydes, and more importantly, the nitrosamines, like for example, N-nitrosodiethylamine. So these are all the carcinogens in tobacco. Now let's try to understand what is the mechanism of carcinogenesis by tobacco. So there are multiple ways by which it can act. First of all, we know that tobacco itself contains nicotine. Now, this nicotine, what happens is when the person is smoking, you're exposed to nicotine, and the bacteria, the normal commensals in the oral cavity, what they do is they convert this nicotine to form nitrosamines, and we have just learned that nitrosamines are very carcinogenic. So that is our first mechanism of action. Second is tobacco causes global hypomethylation and hyperacetylation of DNA. So once it gets absorbed, all these tobacco carcinogens, they require activation by the cytochrome P450 system so as to promote tumorigenesis and their effects. And these effects can be offsetted by detoxifying enzymes like GSTM1. So these detoxifying enzymes, there is actually a dysfunction in these enzymatic pathways that happen, and that is associated with an increased risk of developing head and neck cancers. Third mechanism is chronic inflammation and constant oxidative stress. So, doing smoking actually causes a lot of chronic mucosal irritation and oxidative stress in the region. So, as the injury is repeated from time to time, we have repeated epithelial injury that leads to basal cell hyperplasia, epithelial dysplasia, and ultimately carcinoma in situ. So we have reactive oxygen species from the smoke also, which ends up causing lipid peroxidation and DNA oxidation. So this is our third mechanism where it acts by chronic inflammation and oxidative stress. Last effect is a synergistic effect. So I mentioned that we also talked about alcohol at one point. So a history of alcohol is also important over here, because alcohol and smoking together, they have a synergistic effect, not just with alcohol but also with smokeless tobacco. If you are chewing quid or any gutka or kheni, any of those things. So first let's talk about the alcohol thing. So smoking and alcohol together, they have an synergistic effect. What is the reason? This is a very important viva question that you'll be asked definitely if your patient has presented with a history of smoking as well as alcohol. What alcohol does is it increases the mucosal permeability to the carcinogens of tobacco, and this is because of the increased solubility of these carcinogens in alcohol compared to our normal aqueous saliva. So basically, alcohol is increasing the mucosal permeability of all the carcinogens that is present in tobacco. Second is smoking and smokeless tobacco like gutka, khani, betel quid. They also have a synergistic carcinogen effect together, and this is actually a very common reason why we see a lot of cases of oral carcinoma in India. This combination, both of these combination actually easily leads to malignant transformation of the Leukoplakia, Erythroplakia, or oral submucous fibrosis to develop a carcinoma. So these are our four mechanism of action of carcinogenesis by tobacco, and we have learned that we have a synergistic effect over here with alcohol and smokeless tobacco. Next, now we have learned that a patient has a history of using quid. Now let's try to understand how does quid contribute to cancer. So the betel quid that they usually have, it is a combination of areca nut, slaked lime, betel leaf with or without tobacco. Now when usually you'll know that this quid is usually kept in the buccal sulcus. Some people keep it on the left side, some people keep it on the right side. And usually when these people end up having buccal carcinoma, it is on the side that they use to keep the quid in. So what happens is, because they keep the quid in there for a long time, sometimes for even throughout the day, the whole day, or even at night when they are sleeping, that leads to increased intense prolonged site specific exposure. Therefore, that is the reason how you can see that betel quid users have a predilection of buccal mucosa cancer. So, as you repeatedly place quid in the same region, it is leading to chronic mucositis, ulceration, fibrosis, and release of interleukin 6, TNF alpha, and TGF beta. All of these factors together, it leads to the development of a very pro carcinogenic environment. Let's talk about how each one of the components that I mentioned cause cancer. So first of all, we have areca nut. Now, areca nut has these alkaloids. Like arecolin is a major component, and there's also some tannins. What happens over here? They get nitrosated in the saliva, and they form nitrosamines in the saliva. And we have just learned how nitrosamines are very carcinogenic. Second, if tobacco is added in the mixture, in that case, the carcinogen over here would be the polycyclic aromatic hydrocarbon. Third component is slaked lime. Now, slaked lime, what it does, it's calcium hydroxide basically. It raises the pH in the oral cavity. And because in this raised pH, the conversion of alkaloids or nicotine to free base forms increases, therefore leading to increased mucosal penetration, which can also lead to chemical burns and microulceration. Now, areca also contains copper and polyphenols, which catalyze the reactive oxygen species. And last mechanism of action is mechanical trauma. The coarse areca fibers can actually repeatedly abrade the mucosa. So, this is how betel quid can actually lead to the development of oral cancer. So, we have discussed all the history points over here. That completes our history. Now we'll move on to the examination. So I'll skip over general and systemic examination over here and focus more on the local examination. So coming to local examination, in the oral cavity, mouth opening is adequate, lip and oral commission normal, the gums are nicotine stained, anterior two-third of the tongue is normal, floor of the mouth is normal, no ulcer and swelling is seen here. On inspection of the buccal mucosa, we have noted a single ulceroproliferative growth of size approximately 2 into 3 centimeter in the right buccal mucosa, extending anteriorly up to 0.5 centimeter from the angle of the mouth, posteriorly up to the first molar tooth, superiorly up to 3 centimeter from the upper gingivobuccal sulcus, and inferiorly up to 2 centimeter from the lower gingivobuccal sulcus. Everted edges and irregular margins. Floor is covered with slough. Left buccal mucosa is normal. On palpation, the inspectory findings are confirmed. So the same extent has been described. Then we see that tenderness is present, induration is present, which extends beyond the visible margins around 0.5 centimeter. Base is firm, non mobile, not fixed to the mandible clinically, and it does not bleed on touch. The rest of the areas in the gingivolabial sulcus, the gingivobuccal sulcus is normal. Teeth has nicotine stains, but there is no loose tooth. Retromolar trigon and hard palate are normal. Oropharynx examination is normal. Indirect laryngoscopy is normal. Coming to neck, there has been no significant findings. We have not found any neck nodes to be palpable. And the rest of the examination of ENT region is normal. Now let's start to discuss what we have found in our local examination. So we found that we have a single ulceroproliferative growth which is 2 into 3 centimeter size in the right buccal mucosa. Now what do we infer from here? This ulceroproliferative term that we are using here is what we use when we try to indicate a malignant ulcer. This ulceroproliferative means that it is an ulcer which has rolled or everted margins along with proliferative tissue growth happening. These are all the hallmarks of a squamous cell carcinoma. And the size, the 2 into 3 centimeter size here, if you had to clinically stage the disease, roughly it is corresponding to T2 stage. And we'll talk about the staging afterwards in a little while. Why T2 stage? Because we are saying that it is more than 2 centimeter, but it is less than equal to 4 centimeter in greatest dimension. So from the first line over here, what we have understood is this is possibly a malignant ulcer, possibly of T2 stage. Next point. Here we have described the extent. So we have to, any time when we describe an ulcer, we have to describe the extent of the ulcer as well. The anterior extent, the posterior extent, the superior extent, and the inferior extent. So according to this, what we have found out is that the lesion is restricted to just the buccal mucosa. It has not crossed either of the gingivobuccal sulcus on the upper and the lower aspect. It has not included the alveolus or the angle of the mouth. So since it remains 0.5 centimeter away from the commissure, the oral commissure, and it has not involved the upper or the lower alveolus, so there is possibly no extension into the bone or the skin. This is important for staging because this is immediately ruling out T4A. There is also no extension into the retromolar trigon, floor of mouth, skin of face, which would have, if present, would have indicated a more advanced disease. So a conclusion from the extent of the tumor that we have just noted over here is that the tumor is localized to the right buccal mucosa and it is not infiltrating the adjacent structures. Moving on to the next point. The ulcer has everted edges and irregular margins. So here we need to know what is an edge and what is a margin of an ulcer. If you look at the image over here, this is what an ulcer looks like. Here is the base, this is the floor, this is the edge, and this is a margin. So what is the margin? Margin is this junction that you are seeing in between the ulcer and the surrounding normal epithelium. So this area is the normal epithelium and this is where the ulcer starts. So this junction that we are seeing over here is the margin. The margin forms the outer boundary of the ulcer. Whereas if you look at the edge is the area which lies between the margin and the floor. So you can see that there is a difference between edge and margin of an ulcer. Now, there are a lot of different types of edges that you can see, and each of the type has specific examples of causes. So let's look into what are the different types of edges of an ulcer that you can see. We have undermined edge, we have punched out edge, we have the sloping edge, we have raised and beaded edge, and last of all, we have the rolled out edge. What we are seeing in our case is the rolled out edge. Now let's look a little bit more into each one of these edges and where do we see them. So undermined edge is, if you look at the image over here, from the appearance of it, we can see that the skin or the mucosa is overhanging over the base of the ulcer. This is the base of the ulcer. You can see how it is overhanging over here. And the edge appears as if the ulcer has burrowed underneath the surface, leaving the upper layer overhanging. How does this happen? Why does this happen? This will happen when tissue destruction beneath the surface is more than that on the surface. Then what happens is basically the ulcer is growing subepithelially. So you can see it is leaving behind an undermined edge. This is a characteristic appearance of tuberculous ulcers where caseous necrosis destroys the tissue, leaving the mucosa normal and destroys the tissue underneath the mucosa more, therefore leading to the development of this undermined edge. Second is punched out edge. If we look at the image over here, that the edge and the base, you can see that they are meeting at right angle to each other. The margin is very abrupt and sharply cut. This happens because the sloughing necrosis of all the layers are happening at the same rate. So there is uniform tissue destruction happening, which leads to the appearance of this ulcer. And this is a common example seen in cases of gummatous ulcer, that is syphilis, trophic ulcers, or even ischemic or diabetic ulcers. Next is a sloping edge. You can see how the ulcer margin is gradually sloping towards the floor, and there is a gentle transition happening from the normal to the ulcerated tissue. This will be seen in healing or benign ulcers where epithelial regeneration progresses from the edge and goes inwards. This is a typical example of a healing traumatic ulcer, a venous ulcer, or a simple aphthous ulcer. Next is the raised and beaded edge. So you can see how the edge is actually elevated above the surrounding mucosa, and it is showing some kind of nodularity or beads along its margin. This usually indicates a granulomatous inflammation with tubercle formation. Example of this would be a rodent ulcer. Lastly, the one that we are seeing in our case is the rolled out or the everted edges. We can see how the edge is turned outwards and it is very thickened. It has a heaped up margin, indurated margin, and it has a central crater. Floor is often covered in these cases with slough or necrotic tissue. This is the characteristic appearance of a malignant ulcer. Why does it happen? Because of proliferation of the malignant epithelial cells at the periphery, while the center is undergoing a lot of necrosis. So a lot of proliferation happens in the edges, and the center has a lot of necrosis happening there. This a typical example of this would be a squamous cell carcinoma of the buccal mucosa, the tongue, the lip, etc. So these are the 5 different types of edges of ulcer that we can see, and we have also understood what is the difference between edge and margins. So, as I mentioned, the everted rolled out edges are classic of malignant ulcers, and the irregular margins that we are seeing, they suggest a very infiltrative growth pattern, loss of normal epithelial architecture, and leading to a malignant process. All of these features that we have just noted is helping us distinguish between a carcinoma from a benign ulcer. In case of benign ulcers, it will be a regular, smooth ulcer which will heal very quickly. So these two clinical examination points are indicating towards a morphologically malignant ulcer. Moving on to the next point, we have seen that the floor is covered with slough. Now, what is the floor? If you had seen in the image that we have seen before, this is the base and this is the floor. Floor is basically the exposed surface of the ulcer. Base cannot be seen on inspection, but base is something that we have to palpate. We'll talk about it under palpation. So floor is basically the exposed surface of the ulcer. In our case, it is showing some necrotic slough over there. So this necrotic slough is usually representing tumor necrosis, which is probably happening because of 2 reasons. One is rapid malignant proliferation, which is leading to, because the cells are proliferating so rapidly, they end up outgrowing the blood supply, leading to necrosis. And second is if there is any secondary bacterial infection of the base of the ulcer. So presence of slough over here is suggesting that the lesion is actively necrotic and infected, which is typically of an ulcerative squamous cell carcinoma. So those were our inspection findings. Moving on to palpation, where we have confirmed the extent that we have already seen in inspection. Next, we found that there is tenderness present. Now, what is the reason for tenderness? We know that I have already discussed that malignant ulcers initially are usually painless in early stages because superficial nerves are not yet involved or nerves have not yet been involved. Tenderness will appear when either there has been deeper nerve ending or perineural invasion happening because of the tumor, or second, because of secondary infection setting in. So, here, if we are seeing tenderness, that is probably indicating moderate local invasion or inflammation, which is probably indicating more towards an intermediate stage carcinoma rather than a very early superficial squamous cell carcinoma. Next is we have found that induration is present, which extends beyond the visible margin and around 4.5 centimeter. What is the importance of knowing induration? What is induration? And knowing this number, how will it help us in deciding the treatment planning of the patient? So, induration is basically an abnormal hardening or firming of tissue that occurs because of increased cellularity, fibrosis, or infiltration by inflammatory or neoplastic cells. So, if you see, if the ulcer is this, induration, if this is a malignant ulcer, induration will be actually the area around it, which when you palpate you will feel that there's an abnormal firmness in the tissue. It is not as pliable as the normal mucosa is. So this firm, thickened, hard feeling that you're feeling, this is induration. Now, what is the pathology behind induration? If this is the ulcer, why is the surrounding area is harder compared to the normal mucosa? This occurs, first of all, the first reason is neoplastic infiltration. If the malignant epithelial cells, they have infiltrated the submucosa and the deeper connective tissue, leading to a fibroblastic reaction in the surrounding tissue. This leads to the tissue becoming more firm and fibrotic. Second is if there is an inflammatory response. Chronic inflammation around the tumor will also increase the fibroblastic activity and lead to more collagen deposition in these areas. Third is if there is edema or any lymphatic obstruction, that will also lead to addition of firmness in this area. So induration is basically the presence of tumor cells in invading the spaces, fibrosis in the area, and inflammation in the area. These are the reasons why you'll see indurated area around the malignant ulcer base. Now, what is the significance of this induration? So, this induration, first of all, is the factor that will help you in differentiating between a malignant ulcer and a benign ulcer. Benign ulcer at no level would ever have induration. Induration is typically a feature of malignant ulcers. Second is the induration will help you in assessing the extent of the tumor. Sometimes the visible tumor margin will not be enough for you to determine the true extent of the tumor. Sometimes there is submucosal spread of the tumor which ends up showing as induration. So when you palpate the base and around the ulcer and you find out the indurated area, that is the true extent of the tumor. Third is it will help us in staging. A very firm, fixed, indurated lesion will actually indicate more deep tissue invasion or fixation to muscle or bone. And as we stage the disease, this will also help us in treatment planning. So, finding out the induration will help us determine what is the surgical margins that we need to have during the time of excising the tumor. And last of all, it also determines the prognosis of the case. Greater the induration, more likely that it has deeper infiltration. And if there is deeper infiltration, that is more likely to have a poorer prognosis. So, these are the reasons why we need to check for induration in these cases. Next, moving on, we have seen when we have palpated the base, we found it to be firm, non mobile, and not fixed to the mandible clinically. Now, this part we find out by bimanual palpation. So, what is the base? I mentioned to you earlier in the image. So, this is the base and this is the floor of the ulcer. Floor is the exposed surface ulcer of the ulcer that you are able to see, but base is actually the deepest part of the ulcer that you can only palpate. The base is the part, the tissue on which the ulcer is resting. When we are seeing the base is formed, that means probably there is some fibrotic reaction occurring here because of tumor stroma and inflammation. We have also found it to be non mobile, which means it's fixed to the overlying mucosa. A tumor is probably infiltrating the submucosa. And we have found that it is not fixed to the mandible, so possibly indicating that probably there is no bone invasion over here. Clinically, fixation to the bone will manifest as immobility of the overlying mucosa, tenderness and bimanual palpation, or a grating feeling, all of which will suggest periosteal erosion. Because all of that is not happening here, so definitely we do not have any bone involvement over here. It is possibly just limited to the submucosa or mucosa. So, this is definitely not a T4 lesion, possibly it is a T2 to T3 lesion. Last of all, we have found that it does not bleed on touch. Before we go into that, I wanted to mention that here I have not mentioned about local rise of temperature. Usually, that is something we examine when we are palpating uh, and seeing an ulcer. Here, we are not doing that because when you're examining the oral cavity, you don't just put your finger in directly. You wear gloves, and with the gloved finger, you try to examine the patient. So, with the gloved finger, you will not be able to appreciate the local rise of temperature. So, it is better not to mention that in this case. Okay, so going on to the bleeding on touch. We have found that this is not bleeding on touch. But if it did bleed, what would it mean? If there is easy bleeding on touch happening, it is probably indicating a friable, highly vascular tumor or a fungating tumor. So, this will indicate a more advanced carcinoma. But if it is non bleeding, what could it indicate? First is the lesion is ulcerated and necrotic, but it is not grossly vascular, or that the surface is just covered with a lot of slough and fibrosis. So this will basically point towards the fact that probably the mass is not highly vascularized. Okay, so we have discussed all of these things, and these have all been the features of a malignant ulcer. So from here, a very typical viva question again, and something you should know practically is also what are the differences between a malignant ulcer and a benign ulcer? So let's discuss that. Coming to the number of ulcer, usually a benign ulcer is a single ulcer, whereas malignant ulcer can be single, but it also can be multifocal. There can be multiple malignant ulcer. Something that we need to know, that is field cancerization. We'll talk about it in a little bit. Coming to the shape of the ulcer, usually benign ulcers are round or oval and has a very regular outline, whereas malignant ulcers are very irregularly ill-defined outline. Coming to the margins and edges, benign ulcers have sloping edges merging with the surrounding mucosa, whereas malignant ulcer has everted or rolled edges and sharply demarcated from the surrounding mucosa. Floor, the benign ulcer, the floor would be smooth, clean, and sometimes even have granulation tissue or thin slough. Whereas in case of malignant ulcer, as we saw in our case, it will be irregular, necrotic, covered with slough, and can even bleed on touch, depending on its vascularity. When you palpate the base, in case of a benign ulcer, it will be soft and mobile over the deeper tissues, whereas for malignant ulcers, it will be hard and indurated and may be fixed to the underlying muscle or bone. Induration will be present only in case of a malignant ulcer. Tenderness is seen in benign ulcers, and in malignant ulcers, usually it is painless initially. Later, it can become painful when nerves get involved. Surrounding mucosa usually is a normal healthy color in case of benign ulcer. In malignant ulcer, you may end up finding leukoplakic or erythroplakic patches, which is thickened or fibrotic in case of malignant ulcer. Moving on to bleeding on touch, which is rare or minimal in case of benign ulcer, but malignant ulcer easily bleeds on palpation. And last of all is fixity. Benign ulcer has usually mobile mucosa which is not fixed, whereas in case of malignant ulcer, we'll have fixed because of deeper infiltration. So these are all the differentiating features between a benign and a malignant ulcer in the oral cavity. So the key clinical hallmarks over here that we have found out in case of malignant ulcer is they'll have rolled out everted edges, which is a typical characteristic of a squamous cell carcinoma, indurated base, which will help us in determining our surgical margins. It'll have fixation to deeper tissues, bleed on touch, and they'll probably be associated with hard and fixed cervical nodes. But this is not a necessity, it depends on the primary. Rest of it, we found that gingivolabial sulcus and all of that has been normal. We also examined the oropharynx and we also saw the larynx with indirect laryngoscopy. Now, there's a term which is known as field cancerization. We'll talk about it now. There is a reason why we are checking not just the oral cavity but other areas in the upper digestive tract as well. So, what is field cancerization? Field cancerization refers to the phenomena where a large area of the epithelium, which is the mucosa in the upper aerodigestive tract, has been exposed to carcinogenic agents, leading to genetic and mucous molecular alterations throughout the day, thereby predisposing it to the development of multiple primary tumors. So basically, what it's in simpler terms, what it's saying is when you have been exposed to a cancerous agent, which can be tobacco which, from smoking, or it can be in quid users, all of the mucus and the upper aerodigestive tract has been exposed to it. So it is an entire field which has been pre-cancerized. So it is what we find from here is the mucosa is not just becoming cancerous at one spot. The entire upper aerodigestive tract has been pre-cancerized, and any part of it can give rise to a tumor, to a cancer. So it is important that we check not only the presenting site that the patient has come to you with, but examine the rest of the upper aerodigestive tract as well to see the presence of another primary. The two new terms that we are learning here is synchronous and metachronous. What does this mean? Before that, let's also understand what is a clinical implication of field cancerization. First is what I already said, that two or more distinct cancer may arise simultaneously or later. So the presence of multiple primary tumors. Second is recurrence after surgery. You'll see that local recurrence near the resection margin can actually end up being a new primary tumor rather than recurrence of the same tumor. Third is wider the surgical margins over here. Wider excision margins are required in such cases, and histopathological evaluation of the margin is very important. Fourth is surveillance. Lifelong follow up will be necessary in these cases, even after you have removed the tumor completely. And last of all, prevention. It is very important in the cases of oral cavity cancers that you advise the patient to completely cease the exposure of the carcinogen, which it can be the tobacco, alcohol, and any other quid users, etc., to prevent the development of any second primary. Now, moving on to the synchronous and metachronous tumors. What are synchronous tumors? Synchronous tumor is when you have found a second primary malignancy detected either at the same time of diagnosis as the first tumor or within the first 6 months of its diagnosis. And metachronous tumor is a second primary malignancy that we detect after 6 months of the first tumor's diagnosis and treatment. So that's what synchronous and metachronous tumor is. And according to Warren and Gates, which is the most widely accepted criteria for these synchronous and metachronous tumor, the criteria is first is each tumor has to be malignant on histopathology. Second is each tumor must be distinct and separate, arising from its own focus, not happening because of local spread or metastasis. And third is that possibility that one is a metastasis of the other has to be excluded. It has to be a distinct and separate tumor. That is the criteria of Warren and Gates to determine the synchronous and metachronous tumor. So now, after these criteria are fulfilled, we'll look at the timeline. If it has appeared within 6 months, then it is a synchronous tumor. If it has appeared after 6 months, in that case, this is a metachronous tumor. So I hope that I've been able to explain field cancerization and synchronous and metachronous tumors to you, because this is a very important viva question in terms of oral cavity cancer. So in head and neck cancer, particularly the oral cavity cancer, The whole upper aerodigestive tract is the field which has been exposed to the carcinogens. So we have to check all of these regions, which is the oral cavity, the buccal mucosa, tongue, alveolus, etc., oropharynx, larynx, hypopharynx, esophagus, and even the lungs. Now that we have discussed the clinical examination as well and every point that we have noted over there, we'll move on to summarize the case. So, moving on to the summary, what we have is a 65-year-old male who is a smoker and a quid user. They were brought to the OPD with a complaint of ulcer in the inner aspect of the right cheek since the last 4 months, which was insidious in onset, rapidly progressive, initially a size of 1 to 1 centimeter, and then growing rapidly to attain the size of 2 into 3 centimeter. Initially painless, started having pain since last 2 months, associated with loss of appetite. On examination, we have found a single ulcer proliferative growth, and then we have described the extent of the growth. Also, we have found that tenderness is present, induration is present about 0.5 centimeter around the visible margins, irregular margins, everted edges, does not bleed on touch, and the base is firm, non mobile, not fixed to the mandible clinically. So, that is our summary of the patient. Now, what is our provisional diagnosis over here? So, a provisional diagnosis is carcinoma of the right buccal mucosa. Clinical stage is T2N0MX, possibly stage 2. So now we'll discuss how have we come to this diagnosis. What are the points that are in favor of our diagnosis? From the right from starting the history, we have an elderly male. Second, this male is a chronic smoker and a chronic quid user for about 40 to 45 years. And we have found that this is a rapidly progressive ulcer, which is pointing towards malignancy. And when we examined the patient, we found the ulcer to have everted edges, irregular margins, induration all around it, and the floor was covered with slough. All of these things together are all pointing towards malignancy rather than a benign ulcer. So, this is most likely a malignancy of the right buccal mucosa, and then we have staged the disease. We'll talk about the staging in a little bit. Before that, what could be our possible differential diagnosis in this case? If it was not a malignant ulcer, what other possibilities could there be? Starting with the first one, it could be a tuberculous ulcer. If it was a tuberculous ulcer, we would have found a history of cough, weight loss, evening rise of temperature, and night sweats. This is actually a very typical history that we find in case of tuberculous ulcer. And when you examine the ulcer, it would have had undermined edges and irregular flow. Usually, these are painful. We could have found an associated cervical lymphadenopathy where we would have found matted nodes, the cold abscess type. Very rarely, tuberculous ulcers have a primary oral lesion. And on investigation, we would have found it to be acid fast bacilli positive, Mantox test positive, and on biopsy, we would have found caseatic granuloma. So these are all the things we would have found if this was a tuberculous ulcer. Second differential over here is a traumatic ulcer, which is why we were taking the history of trauma if there is any sharp tooth, any ill fitting dentures, or any history of cheek biting. And if it was a traumatic ulcer, on examination, it would have had a softer base with sloping edges and it would have been painful. And these traumatic ulcers usually they heal very rapidly within 7 to 14 days once the causative factor has been removed. And there would be no induration and no lymphadenopathy in these cases. So you can see why this is not a traumatic ulcer. Third differential is a syphilitic ulcer. Now, these are usually very rare nowadays. For syphilitic ulcer, we would need to have a history of STD, ulcers elsewhere, or a previous history of syphilis. And on examination, the edges would have a punched out edge, washed leather slough, and it would be non tender. On investigation, VDRL or TPHA positive, but you would not find the typical appearance that we found in case of squamous cell carcinoma, which is an everted indurated margins. Next differential is deep fungal infections like histoplasmosis or blastomycosis. Important history over here would be to have a immunocompromised history or a history of an endemic area. The ulcer would be a granulomatous ulcer. It can possibly resemble malignancy. Usually, we'll see multiple lesions over here, and on biopsy, we'll find fungal elements. Next is it could also be a chronic granulomatous disease like sarcoidosis. In these cases, we'd be finding non-caseating granuloma, but these are very rare in oral mucosa. And our last differential over here is the varicose carcinoma, which I spoke to you before when I was talking about high risk behavior. Varicose carcinoma is caused by exposure to HPV virus, and amongst them, the more important strains are HPV 16 and HPV 18. So the features that are matching over here is the fact that this is an elderly male and a chronic tobacco chewer, but the appearance of what the ulcer that we have noted does not match with this. Varicose carcinoma would have a more exophytic, warty, varicose surface rather than an ulcerative surface. There will be minimal invasion and less induration, and histopathology will help you in differentiating them. So these are our different differential diagnoses for our case, but our most likely scenario is still a malignant ulcer than any other cause. Now, as we were discussing buccal mucosa, I also just wanted you to know what is the anatomical boundary of buccal mucosa. Anteriorly, it is limited by the oral commissure. Posteriorly, it extends up to the retromolar trigone. Superiorly and inferiorly is the maxillary and the mandibular gingivobuccal sulcus. This is the anatomical extent of the buccal mucosa. Some MCQ questions over here. What is the most common site of oral cavity cancer worldwide? That would be tongue. And the most common site of oral cavity cancer in India is the buccal mucosa, and this is primarily because of smokeless tobacco. When tobacco is used in the form of quid or kheni or gutka, where they put this tobacco in the gingivobuccal sulcus, therefore predisposing them to having buccal mucosa cancer more than tongue carcinoma. Now we'll talk about the staging. So our staging was, clinical staging was T2, N0, MX. So MX means basically you could not assess for the metastasis. For N0, we did not find any palpable lymph node as well. So this is N0. T2. Now let's discuss the staging, T staging. Starting with the T staging, T1 is when the tumor is 2 cm or less in greatest dimension and 5 mm or less depth of invasion. T2 is when it is 2 cm or less in greatest dimension and more than 5 mm but no more than 10 mm of depth invasion. Or if the tumor is more than 2 cm but not more than 4 cm, which our tumor falls in. Our tumor was a size of 2 into 3 centimeters. So we can see it is more than 2 centimeter, but it is not more than 4 centimeter. And depth of invasion in this case would be no more than 10 mm. So our case has fallen into T2. Now, depth of invasion is something that we cannot assess clinically. We would need the help of imaging to assess this. So just on the basis of the size of the tumor, we are saying that possibly the tumor is clinically T2 size. T2 stage, sorry. T3 is when the tumor is more than 4 centimeter in greatest dimension or more than 10 millimeter in depth of invasion. T4A is when it has invaded through the cortical bone into the deep or extrinsic muscle of the tongue, maxillary sinus, or the skin of face. And T4B is when it is invading the masticator space, pterygoid plates, the skull base, or it is encasing the internal carotid artery. So this is our T staging for oral cavity cancer. In our scenario, because there has been no bone involvement or there is no involvement of the any of these structures mentioned in T4, and our size of the tumor is 3 centimeter maximum in greatest dimension, we are classifying it as T2. Moving on to N staging. N1 is when there is metastasis in a single ipsilateral lymph node 3 centimeter or less in greatest dimension without any extranodal extension. N2A is when metastasis in a single ipsilateral lymph node more than 3 centimeter but not more than 6 centimeter in greatest dimension without any extranodal extension. N2B is when the metastasis is there in multiple ipsilateral lymph nodes and none of them are more than 6 centimeter in greatest dimension without any extranodal extension. N2C is when bilateral or contralateral gets introduced. So bilateral or contralateral lymph nodes, again not more than 6 centimeter. N3A, how would you remember this? Here the size changes. Here the size becomes more than 6 centimeter in greatest dimension without an extranodal extension. N3B, what you see new is any case which has a clinical extranodal extension will be classified under N3B. So N1 was where there is single ipsilateral less than 3 centimeter. N2A is again single ipsilateral more than 3 but not more than 6. In N2B we have multiple coming in where it is less than 6. N2C we have bilateral and contralateral coming in less than 6. N3A is more than 6 centimeter and N3B is if you have extranodal extension. So because we do not have any regional lymph node metastasis, we have classified our stage as N0. Next is M0, which is no distant metastasis, and M1, which is distant metastasis. And then this is the staging after you see. So our case was T2, N0, and MX. So that is why we have classified our case as stage 2 carcinoma. Now that we have discussed staging, now we'll talk about a very important MCQ question. And the question is, what is a premalignant lesion and what is a premalignant disorder? What are the differences between them? So premalignant lesions are these very specific visible mucosal lesions that have the capacity to undergo malignant change. And if you had to talk about examples, we'll classify them into the high-risk lesions, moderate risk, and low-risk lesions. High-risk lesions are Leukoplakia, Erythroplakia, and chronic hyperplastic candidiasis. Moderate risk lesions is oral submucous fibrosis, and low risk is oral lichen planus and discoid lupus erythematosus. Whereas when we talk about premalignant disorders, these are some clinical conditions. These are not just lesions, these are some clinical conditions where we see these lesions or mucosal changes which have an increased risk of malignant transformation. So the difference, as you can see, that these are conditions, whereas premalignant lesions are just some lesions that you are seeing in the mucosa. And examples of premalignant disorders would be Plummer-Vinson syndrome, syphilitic glossitis, xeroderma pigmentosum, and Fanconi's anemia. So now we'll discuss a few of these lesions which are very important for us to know. Starting with leukoplakia. What is leukoplakia? This definition is very important to know. Leukoplakia is a white patch or a plaque of the oral mucosa which cannot be characterized clinically or histopathologically as any other disease, and it carries an increased risk of malignant transformation. You can see this is what a leukoplakia will look like. The risk of malignant transformation in these cases is 2 to 10%. Next is erythroplakia. Erythroplakia can be defined as this. You can see in the image here, it is a bright red patch or plaque of the oral mucosa which cannot be characterized clinically or pathologically as any other definable disease. And erythroplakia is actually the premalignant lesion which has the highest risk of malignant transformation of about 14 to 50%. This is a very important MCQ question over here. And thirdly is oral submucous fibrosis. This is a chronic, insidious, scarring disease of the oral mucosa, which is characterized by progressive fibrosis of the submucosal tissue, leading to stiffness of the oral mucosa, restricted mouth opening, and an increased risk of malignant transformation. The risk over here is about 7 to 13%. So our highest risk is in case of erythroplakia. Knowing a little bit about pathophysiology of oral submucous fibrosis. So in oral submucous fibrosis, how does it happen? So the main feature over here is there is areca nut in betel quid. Areca nut contains arecolin, which is an alkaloid, along with copper and tannins. Now, this arecolin, it stimulates fibroblasts and increases collagen synthesis. Copper is also present in this, which is a trace element. Copper increases the activity of lysyl oxidase. When there is an increased activity of lysyl oxidase, it leads to increased cross-linking of the collagen, making it very dense and resistant to degradation. Then there are also some other tannins in the areca nut which precipitate and stabilize the collagen fibers. And betel quid, as I mentioned before, also contains slaked lime. Now, slaked lime, what it does is it enhances with its pH, it enhances the arecolin absorption and increases mucosal injury. And a chronic trauma and a deficiency state adds into the mucosal inflammation and fibrosis. So, hence, all of this areca nut chewing, which contains this arecolin, the copper, the tannins, all of this leads to chronic mucosal irritation and inflammation. This further leads to TGF beta and cytokine release, leading to fibroblast activation. As a result of that, we have increased collagen synthesis and decreased collagen degradation, leading to more collagen deposition happening and more of cross-linking happening. The cross-linking happening because of increased lysyl oxidase activity because of the copper that we are seeing over here. This leads to increased submucosal fibrosis and reduced vascularity, ultimately leading to mucosal stiffness, trismus, burning sensation, and epithelial atrophy, eventually leading to dysplasia and leading to malignant transformation. So, this is the pathophysiology behind oral submucous fibrosis. If you get a case of oral cavity cancer, your questions may end up in this direction as well. Now, we come to the last part of our discussion, which is the management. How will we manage these cases? So, as I've mentioned time and again in all of my case discussion, management will always comprise of investigations and treatments. First, looking into the investigations, we'll be doing routine blood investigations. Then, this first investigation that would be important here is first we have to confirm our diagnosis. And how can we confirm our diagnosis? That is by biopsy of the lesion. Now, it is important to know what kind of biopsy you'll be doing. We'll be doing an incisional biopsy. We'll take the biopsy. What is the site of the biopsy? That is again a very important viva question. The site of biopsy here would be from the edge of the ulcer, where the normal and the abnormal mucosa meet. Why from the edge of the ulcer? Why not the center of the ulcer? Because the center of the ulcer usually contains, in a malignant ulcer, you'll see that there is more necrosis over here. There'll be a lot of necrotic slough present over here. So if you take a biopsy from there, we'll not be able to assess anything at all. Whereas from the edge is actually the area which has the maximum proliferative activity. That is where you need to take the biopsy from to see the normal as well as the abnormal tissue right over there. So, our biopsy will help you in confirming the histopathology as squamous cell carcinoma and the grading of it. Second investigation would be more imaging. So, here we can either do a contrast enhanced CT scan or an MRI of the face or neck. What will we find out with this? We'll evaluate the depth of invasion, if there is any soft tissue involvement, bone erosion, base of skull erosion, proximity to the masticator space, the pterygoid muscles, skin. When will you choose MRI and when will you choose CECT? MRI will give you more soft tissue delineation. So if it is anything related to soft tissue, we'll choose the MRI. But if we want to know more about the bone details, whether the bone has been eroded or not, in that case, we'll choose the CT scan. Next is we can, not in our particular case, but in general in oral cavity cancers, we may also need to do a orthopantomogram, which is an OPG. Why do we do this? This is one of the first investigation that we can do to evaluate for mandibular involvement, especially if there is any cortical erosion. This we'll do if clinically our patient had shown involvement of the lower gingivobuccal sulcus, then there would be a high suspicion of involvement of the mandible. In that case, we'll do the orthopantomogram. Next is ultrasound of the neck. Now, ultrasound of the neck is done for finding out small non-palpable nodes, and if we are suspicious, we can even combine it with the FNEC of the lymph node. Next is chest X-ray or a CT thorax. This is usually done to rule out lung metastasis, though the chances of metastasis is very rare over here in our case. Dental evaluation might be required. This would be more in terms of treatment planning because post-operative radiotherapy sometimes may be required. PET CT. When do we do PET CT? We'll not do in all cases. We'll do it only in cases of oral carcinoma where we suspect a very distant at metastasis, especially in advanced cases in stage 3 and stage 4 of presentation. PET CT is also required in cases of recurrent disease. So that's about all the investigations that we need to do in a case of oral cavity cancer. In our case, we do not require a PET CT, we do not require an ultrasound of the neck as well, and an orthopantomogram. So, as we were talking about the ultrasound, what are the lymph nodes that usually get involved in buccal carcinoma? So, the most common lymph node to involve over here is level 1B, which is the submandibular nodes. And the second more important one is the level 2 nodes, which is the upper deep cervical nodes lying along the upper third of the internal jugular vein, particularly the jugulo-digastric node. This is an important sentinel node in buccal carcinoma. Less common nodes that can get involved is level 1A and level 3 if there is advanced disease present. But the most common ones are level 1B and level 2. Next question is, what are the features on ultrasound that you'll find which will be suggestive of nodal malignancy? This is a very important viva question asked to you. So the answer is size would be more than 8 to 10 mm. This size actually depends on the node that you're choosing. I'm talking about the cervical nodes over here, but for all other nodes, axillary nodes, and inguinal nodes, this number would vary. Then the next feature is the shape will be round. There will be loss of fatty hilum, irregular ill-defined margins, extracapsular spread, central necrosis or cystic change is seen, and peripheral hypervascularity on Doppler. So these are all the features that you would be seeing in a case of nodal cervical node malignancy on the ultrasound. We talked about when we are doing biopsy that we'll also grade the tumor, if it is a well differentiated tumor or a poorly differentiated tumor. The grading that we use is something that is known as Broder's grading. According to Broder's grading, grade 1 is a well differentiated tumor where we see only 0 to 25% of undifferentiated cells. Grade 2 is moderately differentiated where we see 25 to 50% undifferentiated cells. Grade 3 is poorly differentiated where we see 50 to 75% undifferentiated cells, and grade 4 is anaplastic or undifferentiated tumor where we see 75 to 100% undifferentiated cells. So that's about Broder's grading. Next question is, how will we treat? So we have finished our investigation. We have come to the conclusion that this is a well differentiated squamous cell carcinoma of the buccal mucosa. How will we treat our case? So a treatment plan over here will be a wide local excision with reconstruction and an elective neck dissection. Now let's talk about each one of these parts, starting with the wide local excision. So here we'll perform a wide local excision of the buccal mucosa lesion, and it is important that we leave a 1 centimeter margin of healthy tissue all around. Depth will go down to and including the buccinator muscle or periosteum if it is close to the bone. Mandible, we have seen in our case the mandible is not involved. If the cortex has been free, we'll preserve the mandible. But if in investigation we have found that there is cortical involvement, we can do a marginal mandibulectomy. If there is medullary invasion, in that case, we'll do a segmental mandibulectomy. This is what our primary surgery would involve. Now, after you have performed this surgery, this will leave behind a defect. So now we need to reconstruct for this defect. Usually, if it is a very tiny defect, primary closure is enough. But in our case, we have already seen that this is a 2 into 3 centimeter tumor, and with 1 centimeter margin all around it, it leaves a probably 4 to 5 centimeter defect. So what are our options in case of defects? We can either use local flaps or flea flaps based on the size of the defect. If the defect is less than 3 centimeter, we can use local flaps, which can be buccal fat pad flap, nasolabial flap, facial artery musculomucosal flap, and tongue flap, which can be lateral or anterior. Free flaps are radial forearm free flap, anterolateral thigh flap, pectoralis major myocutaneous flap, and fibula flap. So these are all the options of flap that we can use in reconstruction. Next, coming to the neck dissection. So in our case, we saw that this was an N0. Clinically, we did not find any lymph nodes. So in that case, why are we doing elective neck dissection? This is because in buccal carcinoma cases, even though clinically we find them to be N0, there is a 15 to 20% chance that there is occult metastasis present in the T2 stage of the cancer. That is why, so as to not take a chance for recurrence or persistent disease, we will perform an elective neck dissection. Now, what is elective neck dissection? How do you define this? And what are the lymph node levels that we would remove over here? Elective neck dissection is actually a neck dissection that we perform in a clinically negative node stage, which is N0, to remove lymphatic tissue which is at high risk of harboring occult metastasis. So, elective is when we are choosing to remove it despite it being clinically node negative when there is a high risk of occult metastasis being present. So, that is what elective neck dissection is. Now, what are the levels that we are removing in our case? So, in our case, we have seen the most common lymph nodes to be involved is level 1B and level 2. And in later cases, it can lead to involvement of level 3 as well. Therefore, in this case, elective neck dissection would be a supraomohyoid neck dissection, which is also known as selective neck dissection of level 1, 2, 3 on the ipsilateral side. So, we are doing a selective neck dissection of level 1 to 3. This is also known as supraomohyoid neck dissection because we are removing all of the nodal tissue which lies above the omohyoid muscle. So, this is what our treatment is. We have discussed about the wide local excision, what reconstruction we would do after the primary defect is left, and how would we treat the neck disease. Next question after this is, what are the different types of neck dissection that you know? So, according to the AAO-HNS classification, neck dissection can be classified into 4 types: radical neck dissection, modified radical neck dissection, selective neck dissection, and extended neck dissection. And these are all very important viva questions. Again, you need to know over here, starting with radical neck dissection. So, radical neck dissection is when we are removing an en bloc removal of all the lymphatic tissue in level 1 to 5. So, the lymphatic structures removed here is level 1 to 5. The non lymphatic structures removed here is the sternocleidomastoid muscle, internal jugular vein, and the spinal accessory nerve. These are all removed on one side of the neck. Optional, if involved, some other structures that can be removed are the submandibular gland, part of parotid, digastric, omohyoid, fascia, and fat. This is what radical neck dissection is. Coming to modified radical neck dissection, this is when we remove all the lymphatic tissue of level 1 to 5. But this is a modification of the radical neck dissection. So here we do not remove all the 3 other non-lymphatic structures that we mentioned previously. Here we preserve one or more of the 3 non-lymphatic structures which we sacrifice in radical neck dissection. So that's how we have 3 different types of modified radical neck dissection. So the type 1 is when we preserve the spinal accessory nerve and we remove the other 2. Type 2 is when we preserve the spinal accessory nerve along with internal jugular vein, but we remove the sternocleidomastoid. Type 3 is also known as functional neck dissection. Here we preserve all of the 3 structures, the sternocleidomastoid, the internal jugular vein, and the spinal accessory nerve. We only remove the lymphatic tissue in level 1 to 5. So this is what modified radical neck dissection is. Next is selective neck dissection. Here, the only selected lymph node levels that are most likely to harbor the metastasis for a given primary site is removed, and none of the non-lymphatic structures are touched over here. They are all preserved. So, again, selective neck dissection also has different types based on the lymph node levels being removed. So, we have the supraomohyoid neck dissection, which we are doing in our case, where we remove only level 1 to 3. Lateral neck dissection is when we remove level 2, 3, 4. Posterolateral neck dissection is when we remove level 2, 3, 4, 5 along with suboccipital and postauricular node. And central compartment dissection is when we remove level 6 with or without level 7. So these are the different types of selective neck dissection that we know. Last type is extended neck dissection. What is extended neck dissection? Here we are removing additional lymph node groups and or lymphatic structures which is not included in our classic radical neck dissection because of tumor spread. What could be examples of such structures? Lymphatic structures could involve the parapharyngeal node, the paratracheal nodes, mediastinal node, retropharyngeal nodes. And non-lymphatic structures could involve the carotid artery, in hypoglossal nerve, vagus nerve, skin, mandible, parotid, internal jugular, and subclavian vein. This extended neck dissection is usually done for very advanced or recurrent disease only, where the spread has occurred beyond the conventional neck levels. In that case, we'll be doing an extended neck dissection. Next question is, what are some contraindications of neck dissection? If there is the presence of distant metastasis, in that case, doing neck dissection does not matter at all. If there is a fixed neck node, in these cases as well, we cannot use surgery. In these cases, we have to give them radiotherapy as a primary treatment. And if there is a primary tumor which is beyond surgery, in these cases, we cannot perform a neck dissection. We will be doing a radiotherapy instead as the primary treatment. Next question is, what are the indications of postoperative adjuvant radiotherapy? So in our case, we did not require any postoperative radiotherapy. But what are some indications where we may require? If there is perineural invasion or lymphovascular invasion, if it is a poorly differentiated tumor, maybe an undifferentiated tumor according to Broder's grading, which we'll find after histopathological examination. If it is an advanced stage tumor in stage 3 or stage 4, if there is positive margins or very close margin of less than 5 millimeter, in that case, we should give postoperative adjuvant radiotherapy. If we find pathologically positive nodes, even though clinically we have found it to be N0. And last of all, if there is bone invasion. These are all indications where we should give postoperative adjuvant radiotherapy. Last question for the day is, what is residual tumor classification? So you'll hear terms like we should attain R0 resection. What does that mean? So the residual tumor classification has 3 grades: R0, R1, and R2. R0 is when we have done complete resection, which means there is no residual primary tumor at all, both grossly as well as microscopically. The margins are free of tumor. R1 is when you attain when there is microscopic residual tumor, which means grossly the tumor margins will look clear to the naked eye, but on microscopic examination we see that there are tumor cells at the margin. R2 is when there is macroscopic residual tumor, which means not just microscopically, even on gross examination, the gross tumor will remain visible after surgery, which means it is an incomplete removal and known residual tissue has been left behind. We usually try to attain R0 resection in all cases. So, this is all about a case discussion on buccal carcinoma. If you have any more questions that you need to know or any other case discussions you would like to see me cover, please note them down in the comment section and I'll get back to you. Thank you.